Let's get started, and apologies for the slightly late start. Normally we are quite punctual, but anyway, as my time is, it's 2:05 in Singapore, 2:05 p.m. in Singapore on Friday, 30th July, 2021. And on behalf of the SingHealth Duke NUS Global Health Institute, I'm delighted to welcome all of you. I'm Amina Mahmood, I'm Deputy Director of the Institute, and this talk today is part of our monthly Global Health Seminar series. In these sessions, we draw from our faculty as well as invited guest speakers to present topics of global importance that kind of really engage with our community in Singapore and beyond, and we hope to have a lot of interaction with all of you. So our talk today is making an economic case for Egypt's population-wide screening for non-communicable diseases. Presenting this topic is Dr. Dee Dong. Dr. Dong is a health economist in the Health, Nutrition, and Population Global Practice of the World Bank. She works on health financing, social health insurance reform, health service delivery, and hospital management in the Middle East, Africa, and Asia. We are especially pleased to have her here today because she returns to her alma mater. She received a PhD in health economics from Duke NUS. So welcome, Dee. She also holds adjunct assistant professor positions at Duke Durham and Duke Kunshan. She has over 10 years of experiences in health policy research and analytics, design, implementation, supervision, and evaluation of large health programs and reforms, and health policy advisories to government agencies, particularly around the topics of social health insurance reform, health financing expenditure efficiency, health system strengthening, program monitoring and evaluation, and health technology assessment. So you can see she has a really wide range of talents. And today we're going to hear about some of these topics in the context of Egypt. So thank you, Dee, for joining us. And before I hand over to you, a few housekeeping notes for the audience. Please keep yourselves on mute. The webinar is being recorded. And please post your questions in the chat box at any time. Dee will make a presentation and then we'll turn to your questions and address them. So thank you all, and thank you, Dee. Over to you.
Thank you, Amina, for the very kind introduction. So now let me try to project my slides. So good afternoon, everyone, and it's my pleasure to be here to deliver this seminar today on making an economic case for NCD screening in Egypt. So this is really, I want to introduce this policy study that we have done to inform the NCD policies in Egypt. And so this is the brief contents for today's talk. I'll talk about the backgrounds and the objectives, and then the methodology, the results, and also some of the kind of the economic arguments for NCD interventions at the end. So a little bit of context in the country. As Amina has introduced, I work in the Middle East and North Africa region. So Egypt is one of the main countries in my portfolio. So I guess you're all familiar with this country from the movies, from travel, and there are a lot of interesting culture and places to visit. Also, there's very nice food in the North Africa region. So Egypt is the third most populous country in Africa. It has around 100 million population, which is considered a big country in Africa, and is in the North Africa region. So Egypt has an Arab culture, and you may be familiar with the food and also some of the lifestyle there. So due to those diet and lifestyle factors, actually this country has really high burden of non-communicable diseases and obesity. And now quickly zoom into this NCD problem, why non-communicable disease is a big burden in Egypt. So on this map, is the prevalence of non-communicable diseases globally from the Global Burden of Disease study in 2019. So these colors here basically represents the prevalence of NCDs in each country, and the darker the color, the heavier the disease burden. So you can see here the African continent basically has much higher burden for NCD compared to the global average, and Egypt is here, is actually quite high compared to the rest of the world. And then the chart on the right basically is a chart on the causes of death in Egypt. So the larger the square, it means it kills more people. So you can see from this chart that ischemic heart disease, cirrhosis, diabetes, chronic kidney disease, stroke are basically the main killers in Egypt in 2019. And this chart on the bottom left corner basically shows similar things. So the global burden of disease studies basically classifies all the causes of death into 3 big categories: the communicable, nutrition and maternal diseases, and the non-communicable diseases and injuries. So you can see among the top 10 killers in Egypt, most of them are blue in color, means they're non-communicable diseases, and those are the top killers. So in Egypt, NCD accounts for 82% of all the death and 67% of the premature death. So it's really a big public health concern to the country. And in terms of the top causes, top diseases, they are ischemic heart disease, liver disease, stroke, kidney disease, hypertension, diabetes, and COPD. So after looking at those diseases, you may realize a big proportion of those can actually be prevented. So that's kind of how our study started. And I also want to introduce to you the economic burden of NCDs in Egypt. So this is also something for us as economists we consider, and also for the government. When they make decisions on NCD policies, they kind of consider also the economic impact, the social impact of the policy beyond the health sector. So hypertension and diabetes cases basically cause a lot of economic burden in the following areas, right? So one is the current medical cost. So those people needs to be treated, and in countries where the government pays for the medical costs or the social health insurance pays for it, this is actually a huge expenditure for the government or the social health insurance program. And the second is actually those future medical costs. So for instance, if diabetes is if diabetes and hypertension are not prevented right now, not well managed in the future, this person might have more issues like stroke, ischemic heart disease, which again are very expensive medical conditions to treat. So future medical costs. And the other dimension, which I think the global community is paying more attention, is the productivity and the human capital impact of disease. So for instance, there are a lot of studies which basically shows that the people with diseases and disabilities, they not only die early than the healthy population, but also when they work, they have lower wage, or they have lower working hours compared to the healthy population. So their productivity and their human capital are also compromised by those health conditions. And eventually all of those gets translated to economic growth. So in the case of Egypt, there's a study on the economic loss due to diabetes. And in 1 year, in 2010, this cost is around $1.3 billion US, which is quite huge. And when all the chronic conditions being aggregated together, the productivity loss is equivalent to 12% of Egypt's GDP. And without the intervention, the economic burden is expected to double by 2030 with population aging and the trend of NCD expanding. So this number, 12% of Egypt's GDP, is a pretty huge economic burden. So in the next slides, I basically want to introduce to you how this NCD policy kind of fits into the broader health system reforms in the country, right? So when we talk about NCD policies, we talk to the Ministry of Health, the Ministry of Finance, Ministry of Planning, etc. So they kind of have some slightly different perspectives on how they think about NCD policies, right? So, but usually those are the aspects they consider. here. So number one is, of course, the health outcome and the human capital, right? So, you know, for the SDG, there are targets on life expectancies, on premature death, etc. So countries kind of set their own targets, and then they compare where they are now with where they're moving to. So here you can see in terms of life expectancy, the increase is quite slow for Egypt, and up to now is around 72 years, which is still quite far from the SDG targets. And in terms of the premature death due to NCDs, also is on an increasing trend, whereas the target is by 2030 is to reduce to around 20 to 25%, but now is around 30%. So there is a long way to go. So in terms of health outcomes, more NCD policies are definitely needed to really ensure the country meets those health targets. And human capital, of course, basically based on the previous slides, how those mortality or compromised productivity basically translates to GDP. And then the next aspect is really how to plan their health resources based on the disease burden, right? So whether there should be a focus from hospital away to primary care and preventive care, or what kind of resource allocation they should really do to optimize the healthcare system for NCD management. And then the other important dimension is the health financing dimension. So this is kind of the health financing system in Egypt. So Egypt, starting in 2019, starts to launch the universal health insurance system, which is expected to provide coverage for the whole country. And there are three main types of sources of financing. So some of it comes from the tax and fees collected by the government. Some are from the individual and employer contribution. And the other part will be the government subsidies for the poor people who cannot afford the premium. And then they contribute to the universal health insurance system as a single payer in the country, which eventually pays for health services in the public facilities and also the private facilities. So in this case, NCD actually eats up a huge proportion of the budget of the UHIS. So the question from UHIS is that, how can I spend my budget more efficiently to make sure with the amount of reimbursement I get better outcomes? And also, how do I ensure my physical sustainability, right? Because NCD is on an increasing trend, but my budget couldn't grow indefinitely. So how do I make sure in 10 years time, I still have enough budget to cover all those health expenses of my people? So those are actually some of the very realistic questions that the different stakeholders in the healthcare system have been thinking about. So that's why we decided to work with them to tackle this issue. So to address the NCD burden, basically Egypt did a 100 million Seha campaign, is 100 million healthy lives campaign. So how this started is that Egypt has a really high hepatitis C burden. So there is very high level political view to eliminate hepatitis C. So the president launched a Hep C elimination campaign to screen for the population for hepatitis. So at that time, the World Bank is providing a loan, a $400 million loan to the government to support the Hep C campaign and elimination effort. So at that time, we thought NCD is a huge burden, and why not just add NCD screening also to the campaign, right? So this is how this campaign came about. So this campaign has achieved quite huge progress. So this is the results by the end of 2019. So by then the campaign had screened 60 million adult population and managed to detect 2.7 million hepatitis C cases, and then offered free treatment on hepatitis C in the government clinics and health and treatment centers for those people who screen positive. And on the other hand, the screen also detected 2.6 million diabetes suspects and also 10 million hypertension cases, and as well as obesity have been measured from the campaign. So those are some pictures from the campaign. So basically, in each of the screen posts, there are like 3 healthcare professionals. One is the nurse who is now like poking the fingers to collect the blood sample for the diabetes measurement and also hepatitis C measurement. And then the other person will enter the data into a mobile tablet, which is uploaded to the central system. And the other person is there to measure the height and weight, the blood pressure, etc. And there are also those mobile vehicles, which is used to drive around. So this is one of the city squares in Cairo. So this is to make it easier for the population to receive the screening. So this screening results is pretty impressive. And back then we were thinking, after you found so many cases with potential hypertension and diabetes, what do you do next, right? So what's the policy you're going to implement next? So there are various options out there in the guidelines, in the literature. For instance, you can provide free diabetes and hypertension treatment to people, or you can have the universal health, the social health insurance program cover the treatment, and they go to public or private facilities for follow-up management, or at the more kind of on the public health and policy level, they could incur a sugar tax to tax the sugar drinks, soda, Coke, etc., to really try to reduce the consumption and reduce the risk factors of obesity, diabetes, and hypertension. Or there could be other public health interventions or school-based interventions. So there are so many options out there. So the question that we discussed with the government is that, so what are the costs and returns of each policy or program? So what are the high value programs and policies you should really implement? So this is kind of more from the policy perspective of Egypt, and in the kind of the broader NCD literature, there are also some debates on the value of population screening. So you might find the screening of high-risk groups more common, but it's kind of debatable whether it's feasible to do very large-scale populations in this screening and management, and is it cost-effective to do so? There is a very mixed evidence in the literature. So this is also a point we're trying to address to see for a middle-income country like Egypt, is this kind of large-scale population screening really a feasible and a cost-effective option? And is this potentially also feasible in the other countries? So based on those, we basically formulated our study objectives. So the first one is really trying to estimate the cost of this screening and treatment over the next 15 years. And also look at the overall expenditure and also the share of government expenditure for their budget and planning purposes. And then number 2 is to estimate the benefit of screening and treatment. So there are a few indicators we use. We use the health benefits in terms of death and the disability adjusted life years, DALYs. And we also look at the productivity gains and also potential future medical costs or savings because of the early diagnosis and treatment. It is going to save money later. So this is particularly important because Egypt is moving towards the universal health insurance. So eventually all those will be on the bill of the insurance program. So they're very keen to really find out what's the longer term and immediate term impact on them. And then the next one is to really assess the value of screening and treatment, the cost effectiveness, the return to investment. And lastly, we also supported them with a review of the cost effectiveness of public health interventions for NCDs, to kind of have a holistic approach of NCD management. So here I'm going to show how we measured the impacts. So basically, this is kind of the cascade. We start with screening and identify those cases of hypertension and diabetes, and some of them will link to care, whereas the others will just ignore the information and do not seek care, right? And among those who seek care, there is a proportion of them who will be well controlled under the medication, whereas in the for some of the other people, they wouldn't respond to medication, or the medication adherence is very poor. So for those two, we basically got information from the household surveys, the health surveys in Egypt, which tells us in the population what's the percentage of linkage to care and what's the percentage of treatment success. And for those treatments who have good management outcomes for diabetes and hypertension, they will receive the benefits: improved health, reduced mortality, lower future medical costs, and better productivity and human capital. And on the aggregate level in the country, there will be better economic growth. So basically, those are the indicators we use to quantify the benefits of screening. So this is a methodology overview. So for all the inputs, we modeled over a 15-year time horizon, as NCDs are chronic conditions, right? And we used a 3% annual discount rate, and take a health system perspective as well as the government financing perspective. And in terms of the data sources, we got the campaign program data from the Ministry of Health and Population, and also some of the literature from Egypt and from globally on NCD management, as well as the disease burden data from the Global Burden of Disease study. And for the cost, basically we included a few types of costs. One is the NCD screening cost per case, so this will be a one-time cost, and the second will be a long-term cost per year for diabetes and hypertension treatment cost. So this is also obtained from the data of a free government program for hypertension and diabetes. So they basically provide free treatment for this group, and they have the total expenditure of those people. So this includes all the inpatient and outpatient costs incurred. And there's also a third type of cost, which are the treatment costs for other medical complications caused by hypertension and diabetes. For instance, stroke, IHD, chronic kidney disease. So basically for this one, we identified the treatment costs for each of those conditions in Egypt per episode, and look at the proportion of disease burden of those that can be prevented by preventing diabetes and hypertension, and estimated the treatment costs that can be avoided. And also we did some estimation on the public and private, because the public part will be basically paid out of the government budget. And also there are data on the prevalence, incidence, and mortality of medical conditions, and we got those from the medical literature. And in terms of the benefit, so basically the key inputs are the number screen positive for hypertension, diabetes, the linkage to care, the treatment practice, the treatment success rate for those in the Egypt healthcare system, and also the wage loss due to NCDs this is from the labor statistics. So in the end, all those health benefits are monetized based on the market wage, the employment rate, and we applied in the end a willingness to pay to avoid deaths, which is 1 times per capita GDP by the global standard. So that is a summary of the methodology, and here are the results on the cost. So for this campaign cost, actually, if you look at this cost distribution, the screening cost is actually quite not that big. So the total cost is 132 million US dollars to screen 60 million people. So around $2 per person. And among the screening costs, actually most of it is to purchase the medical diagnostic supplies, those testing kits, and also for media campaign to make advertisement in the media to encourage the population to go and screen. And the employee wage, again, is a big component, which is paid out of the budget, and the logistics cost is actually quite small. So this is considered a quite economically quite economical screening at the cost of $2 per person. But compared to the initial screening cost, you realize the follow-up treatment cost is much higher. Over 15 years, the total cost you needed to manage diabetes and hypertension is 4.9 billion US dollars. So it's around over 400 million US dollars per year. And then on the health benefits, so we basically did a counterfactual baseline analysis. So what if there's no screening, what's going to happen, right? So among those 60 million adult population, there would be over 12 million hypertension cases and over 3 million diabetes cases remain undetected in the population. And those people have a higher mortality rate. So for hypertension, the mortality is around 0.49% per year, and for diabetes, it's around 0.29%. So applying this rate, basically for hypertension each year, we expect to see over 60,000 deaths and over 8,000 deaths per year due to diabetes. Whereas with hypertension, diabetes screening, and follow-up treatment, the case is going to be different, right? So those people will be identified and referred to treatment. So the linkage to care here is 68. So most of them will go to seek care once they know that they have hypertension. But the treatment success is only around 50% currently in Egypt. So that means over 4 million of people who screen positive will be treated successfully. And then the death is going to be much lower. So there's going to be a 32% reduction in mortality due to hypertension with the screening. And for diabetes, there's going to be a 26% decrease in mortality due to diabetes with the screening. So here is a summary of the health benefits. So compare the baseline without intervention and the with intervention. Each year, this program is going to save 20 million lives for hypertension alone, and another 2,000 deaths with diabetes. And then on the productivity benefit, so basically now the monthly wage, the average wage is around 4,800 Egyptian pounds, and for those who suffer from diabetes and hypertension, there is at least a 10% wage loss. Whereas for those who are managed well, there wouldn't be this wage loss. So applying this, basically, we get the total productivity of those with program and without program. So here's the result. So without the program, in a year, the productivity loss due to hypertension will be 2.2 billion US dollars, which is equivalent to 0.88% of Egypt's GDP in 2018. And for diabetes, the loss will be over 500 million, or 0.22% of Egypt's GDP in 2018. So adding together, it's around 1% of the GDP, which is quite a big number. But with the intervention, so this is going to be the productivity loss. So there is going to be an overall 0.35% of GDP that can be saved by doing this screening and treatment program. So if we add this up over a 15-year time horizon, the total productivity benefits will be around $10 billion. So this is the part on the future medical savings. I think this is kind of one of the main arguments for NCD early management and NCD prevention, is that it can prevent a lot of medical conditions subsequently. So those are, so for diabetes and hypertension, there are very clear literature on some of the future complications, right? For instance, there are risk factors for stroke, for ischemic heart disease, for chronic kidney disease, which are the top killers in Egypt, as you have seen in the previous graph. So basically, there is a proportion of those diseases which are attributable to hypertension and diabetes. And we're basically trying to say if those parts can be prevented, what's going to be the future medical savings. So for stroke, if we can prevent hypertension and diabetes, we will be able to kind of prevent half of it. So the savings will be $15 million for Egypt. For ischemic heart disease, the savings will be 22%. For chronic kidney disease, the savings will be over 130 million. So overall, there's close to 170 million cost savings, which is quite big compared to the current health budget, which is invested to cover all those conditions. So now this is the overall cost effectiveness and return to investment. So basically with screening and follow up, there is going to be a cost of $5 billion over 15 years. But in terms of the benefits, right? So productivity wise, the gain will be $10 billion USD. And for future medical savings, it will be $2 billion. USD. And in terms of deaths, over 300K deaths will be able to be prevented by this program. So adding all those together, the cost benefit ratio will be 2.46, which means for each dollar invested into the management program right now, the return will be $2.46 in the future. So this is considered a very good return to investment. And then let's also apply this daily standard of GDP per capita to see if this is cost effective. So in this case, to prevent one disability adjusted life years, the cost is only $1,000 So this DALYs basically means the cost to buy 1 year of healthy life is around $1,000. So it's considered very cost effective because it's much lower than Egypt's GDP per capita. And it will be a good investment from the public financing perspective. And then we basically did some sensitivity analysis. So particularly, I want to show you this one because the whole benefits of screening is to link it to treatment and have the patients properly managed. And also Egypt is actually implementing quality improvements projects to improve the service quality in the public facilities. So hopefully with this, the treatment success may increase, and with more kind of advocacy campaigns, with awareness improvement, more people will go to seek care once they know their risk. So the linkage to care in the future hopefully will also increase. So we did some sensitivity analysis to see if those two factors change, what's going to be the program benefits. So in this hypothetical scenario, if say the system managed to treat 90% of the patients with good outcomes, and 90% of those diagnosed go to seek care, and then the cost benefit ratio will increase to 2.0, which is really good. And for this one, also it's a sensitivity analysis done on the number of lives saved. So in this hypothetical scenario where the linkage and treatment success both increase, we'll be able to save over 800K lives. So this is to show how those factors basically is going to change or increase the program benefit. So that's the study. So basically the study was done jointly with the Ministry of Health and Population. And based on this, I think there is a very strong argument to scaling up the NCD management, either for free in the public facilities, or for it to be covered under the universal health insurance. And on the other hand, really trying to increase the linkage to care and the treatment quality to really manage the conditions properly. And then after that recommendation, there is kind of a request coming from the ministry on kind of a broader package of NCD interventions. So what are the other good interventions from an economic perspective? So we did another kind of literature on the best buys and cost-effective public health interventions for NCD. So those are basically the 4 categories. So just one note on the terminology. So best buy in this case basically means if an intervention has a incremental cost effectiveness ratio of smaller than 100 international dollars per DALY, is considered a best buy. So if it's higher, if the ICER is higher than $100 per DALY averted, is considered effective. So, so there are 4 categories. The first category basically targets the diets and the food consumption. So reduce the salt intake through reformulation, labeling, and public campaign is a best buy. Reducing industrial trans fat through legislations or incur sugar tax through tax policies and laws are effective interventions. And then the second class targets tobacco. So as you can see here, all those interventions targeting tobacco are best buys because it's really a huge factor, risk factor to NCDs and mortality. So the typical, so the typical interventions, one is excess tax and increase the price. And number 2 is the package regulations. For instance, in some countries, the tobacco package is very nice. It's like luxury goods, but there are graphic warnings, which is requested by law to really make it ugly, make it scary. And also in some countries, they ban on tobacco advertisement. And also there are mass media campaigns on tobacco cessation and the harm of tobacco. So all of those are best buy strategies. And then the third class targets alcohol. So typically incur tax and also bans and restrictions on the advertisement are the very typical policy tools used. And then the last one is on physical activity. So there has been a lot of community-wide campaigns and some school-based educations on physical activity. So those are also considered best buys. So I want to show you some of the examples on those. So typically when they make policies, they will distinguish some of the fast-acting policies with the longer term interventions. So for instance, the fast actings, most of them are tax or advertisement. So usually those require multi-ministry coordination. For instance, the tax is generally designed by the Ministry of Finance, the tax authority, etc. So all of those are actually beyond the health sector and really require multi-sectorial collaborations in implementation. Whereas those are the public health interventions, which the Ministry of Health tends to be more concerned on smoking cessation programs, salt reduction programs, or physical activity programs. And here is a kind of tells you what's the return to investment for some of those NCD interventions, right? So here is a rank of the best buys. So those are the cost per dollars averted, and this table is the return to investment. So basically, you can see for salt reduction in manufactured food, it's one of the most cost-effective strategies. For $1 invested, you get a return of $19. And for salt interventions, alcohol interventions, tobacco interventions, again, it's really high. And for CVD clinical intervention, the return to investment is 3. So compared to our previous study, if you recall, the return to investment is around 2. So this basically tells us those public health interventions that targets NCD prevention are usually more cost-effective than those focusing on early diagnosis and management. But again, it's still much more cost-effective than leaving it, which ends to be the most costly strategy. So here is a quick summary. So basically, we estimated the potential benefits of this campaign and follow-up treatment in terms of health benefits, in terms of productivity benefits, and also the future medical savings to the healthcare system and to the universal health insurance program. But to note here is that to achieve those benefits, the campaign really needs to follow up with very high quality treatment, which was what we're trying to push for the next stage. And then many of the public health interventions also have very good return to investment, are very cost-effective ways to combat the NCD. So that means in the kind of the NCD management or the NCD policy area, we should really look at a multi-sectorial approach and also do a combination of clinical plus public health plus the broader policy interventions to form a package to tackle NCDs. And then lastly, so as you know, Egypt is a middle income country, but it demonstrates that it's possible to do a large scale NCD screening at reasonable cost and also producing good returns. So this could be kind of a something for the other low and middle income countries to consider in terms of NCD early detection and management. Yeah, so here is basically the package, the comprehensive approach to combat NCD that we kind of developed based on the study. So I'll stop here and thank you. And I'm happy to take comments and questions. Now over to you, Amina.
Dee, thank you. That was amazing. Lots of information, lots of data. You guys collected a huge amount of data, and the analysis was really interesting to also, I think, for our audience to link it, you know, beyond the just health interventions, but really look at it from an economic point of view. While the audience is kind of thinking of questions to ask, maybe I'll ask a couple of questions that, you know, kind of arose through your presentation. So you talk about, you know, the screenings and the impact. What maybe you did touch about, and I'd be really interested to know, is how do you take different demographics into account, you know, because there are a lot of social determinants of health that impact the way we can access health. So kind of the way this current presentation was, it was a generic thing for everyone, but I'm sure there are a lot of kind of differences amongst the group, and how do you account for those and make sure the most marginalized are also part of it?
So thanks, Amina, for that question. I think it's a great question. So that's actually one of the kind of a key challenge in some of those programs, right? So as we know that so ethnicity may kind of links to some of the genetic risk or the lifestyle factors may make a certain group more susceptible to those conditions. And on the other hand, this kind of also sometimes links to socioeconomic factors which impacts their access. For instance, during the time of screening implementation, they actually have challenges in some of the remote areas. People don't like to go for screening, or in some places they find that women are it's kind of more difficult for them to get out of the household to receive screening. So in that kind of the implementation, there are various ways to try to make sure those are also covered in the campaign. For instance, there are those kind of women kind of support groups. And a lot of female community health workers really go household by household, try to encourage them to do screening and do those education to tell them what those are, what you should do if you find you're positive, things like that. So I think in the implementation of public health programs, how to ensure the access of those, sometimes those are the vulnerable populations, right, are really important to consider. And I think there's also kind of a broader perspective on how to ensure those people receive good quality care and good access to care. So I think there's a big like a social welfare component to it. So it's quite there's a lot of evidence in the literature that those from higher social or income groups, they tend to use more healthcare and they have better health outcomes. So I think in this case, kind of a moving towards universal health coverage to provide coverage for those people and also help them to get the literacy, the medical literacy to seek care is also very critical. And I think in the case of Egypt, the way to do this is through the implementation of this universal health insurance program and providing government subsidy to those poor people and for some of the vulnerable groups to ensure them health success. And also there are other kind of social programs targeting the vulnerable in most of the countries. So I think those are actually very critical parts to kind of NCD management and prevention to the whole healthcare system to ensure that the policies are not kind of standing alone, to make sure they really reach the whole population, reach the target population, the high risk population, and kind of eventually move towards universal health coverage.
Okay, great. Yes, those are some of the important things to kind of think about. So maybe I'll pick up on something you mentioned about, obviously, throughout this, the role of prevention. You showed how cost effective it is, but it's not an easy thing to actually do, as we all know. So really, what are the kind of ways that you can structurally, and I'm always wary of when the prevention is left too much to an individual. So it's like, oh, it's your choice of how much you eat or what you eat and how much you exercise and all. But actually, in reality, it's not just you, right? It's the environment you live in, the structure you live in. What are your work policies? What is your built environment? So what are on that element? What work has been done in Egypt? To really kind of make sure that from a structural point of view, prevention is possible.
Yeah, so that's another very good but very hard question. I think we all kind of agree on the why is important, but on the how, I think we kind of all really try hard to think about innovative solutions. So I think from what I see, there are kind of kind of three different ways of doing it. One is more from the traditional public health approach, like do massive campaigns and screening, etc. And then the other way is really economic incentives and mostly rely on tax. For instance, Egypt has the tobacco tax, and also many countries are now also moving towards sugar tax. So we're actually supporting the Ministry of Finance to design the sugar tax policies on kind of what kind of drinks we should tax, what should be the tax rates to really make it effective, to change the behavior, how that's going to influence consumption, import. So it's a whole kind of agenda, but that is kind of a very common tool that countries use. Also, I think some countries start to tax the trans fat in the manufactured food. So that's so tax is kind of the economic incentive, the economic tool for it. And the other kind of more uprising area is the behavior economics approach. So I think actually Singapore is a very good example on this. The system, the medical savings account, kind of really emphasize on the individual responsibility for healthcare, right? So even though it's in your in an account, but it's kind of your own account, and if you are healthy, you can save some money there. So I think this is a very good type of kind of a policy architect or choice design, a choice architecture design, which kind of nudge people towards more self-responsibility. And this is also kind of more also used in the other countries to kind of link it to some of the behavior incentives and to design the system so that people kind of behave in a healthier way.
Yeah, those are certainly, things to try and hope it works. And this maybe leads to the question from the audience where someone has asked, what is the criteria to differentiate between fast-acting policies versus longer-term policies?
Okay, so fast acting, basically it just means, for instance, a tax policy, once you have it, you start to work immediately, right? They start to collect tax, and it might take some time for the consumer to realize, oh, there is my Coca-Cola is more expensive, and then they start to decrease their consumption. But it's considered very short because once the tax policy is incurred, it starts to work immediately. Whereas, and it's sometimes you can think of it like as a one-off policy, right? So once you have the policy, it's going to be there for long term. Though countries do regularly adjust their tax rates or the tax policies, but it's kind of less frequent. Whereas for the longer term policies like campaigns, advocacy campaigns, screening campaigns, it takes a much longer time. And you do it this year, maybe you do it for a year, and then you have to do it in the longer term to really change people's perceptions and behavior. So those are the more longer term policies versus the fast acting policies. So in the health sector, there are very little fast acting policies. Is mostly with the kind of the tax authority or Ministry of Finance, etc.
Yeah. Okay, so thanks for that. And I think now just looking at the time, maybe one of the two last questions, maybe if I'd ask you to address, and you can see how they might even overlap in certain ways, is, we have this, of course, double burden of disease. It's a well-known concept, and it's kind of been there in the background for many years. NCDs was beginning to get more attention, just as your study shows. Then, of course, we have this huge pandemic, which is an infectious disease, issue. So, do you see that health financing models or any other kind of interventions now will kind of, again, not focus on NCDs too much? And what is the danger of that? And maybe just because, we are sitting in Singapore, we work a lot with the ASEAN countries, and in Asia, maybe you can pivot that answer to, considering how that is in the context of ASEAN and Asia particularly.
Yeah, so that's a good point. So I think NCD by now has already received a lot of attention, and I personally I don't think the attention is going to go off soon. So the reason is that many of the countries you mentioned, like those ASEAN countries, are still having the demographic transition. So Singapore is kind of considered one of the most aging countries, right? Singapore, Japan are kind of the most aging countries in the world, whereas the other countries are much younger, particularly some of the low and middle income countries. The fertility rate is still quite high. The population growth is quite high. For instance, for Egypt, the adult population only consists of 60% of the total population. So there is a very big group of young people. So with time, I think a lot of the younger people are going to grow older. And with the trend of aging, the burden of NCDs are going to increase, right? So it's not a problem that we think we can solve in the short term. But I think the only thing to do is probably more to really prevent those conditions or treat them early to prevent it from getting worse. So I think particularly for many of the Asian countries that are having much younger population, with population aging, they're going to see more and more of NCD burden coming up. Yeah, so I think it's not something that can be reversed in the near future.
Yeah, okay, that's something I think we just will struggle with, both the infectious diseases and the NCD burden, and there's a lot of work still to be done, but certainly efforts like the ones you just described help kind of pay attention, make us pay attention to it and see. I hope the policymakers from across different countries, not just Egypt, where your study is based, kind of keep this in mind as they think of what finances to allocate to different sectors of the society and for different activities within the health sector. Prevention is certainly, comes out always on top, and we sometimes wonder why there's not more effort to it. But with that, I will say thank you for a really interesting presentation. I hope the audience enjoyed it as much as we did. I'd like to thank all our team for organizing this. Apologies for the few minutes delay in the start, and it will be available on our website and the recording and as well as your slides, Dee. So for anyone who either would like to refer back to it or would like to send it on to other people, you're welcome to do so once it's released. And thank you again, Dee. It was wonderful to catch up with you, and I feel very proud of you being a Duke NUS alum.
Thank you, Amina, and it's really a pleasure, and I feel really happy coming back to share my experiences and hopefully get to engage more with the colleagues in Singapore.
Great. Bye-bye, everyone. Thank you.
Thank you all. Thank you, everyone. Bye.
Bye.